again, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me again, well, we go back a year and a half with this doctor. I was surprised that it's already been that long ago. Dr. Joseph Tuma is here. He's an interventional cardiologist and an expert in the field of coronary and structural interventional cardiology and peripheral vascular disease. Got through it all perfect. That's got to feel good to hear that out loud, doesn't it, all the time?
Bit of a mouthful there.
Exactly.
Right.
No, I'm glad to have you back, Doctor. I know we talked, we go all the way back to episode 30, I think, was the last time you and I got to have a conversation, and we were talking about TAVR, which is the transcatheter aortic valve replacement.
Yes,
correct?
That's right. Yep, you got it.
Has there been anything new and exciting in that field a little bit?
Yeah, both of there are now 3 valves available in the United States. One called Navitor from Abbott is kind of the newest valve on the market, and then the big valves, including Core Valve, which is the one we use most of the time here, and then Sapien, which is made by Edwards. Their devices have evolved, and the Core Valve now has what's called Pro Plus, which is they have specific little windows cut in the valve, so we have easy access to the coronaries if we need to get back in. The first valve, outside the study was just implanted a couple weeks ago.
Oh, wow.
And so hopefully we'll have that, I believe next week, we'll do our first Pro Plus valve. So.
Well, I encourage everybody to go back and check out that episode for sure to kind of, get a breakdown of what you're referencing here. And now that we've got some cool new stuff, it'll be fun to listen to for sure. Well, we have you in here today, Doctor. I'm half excited for this topic as well because, I don't know, about a year and a half ago, I went through a bout of AFib.
Oh, interesting.
Yeah.
Okay.
So it's one instance. That's all it's been. I've been through a lot of the testing and stuff since then, and so far everything seems fine.
Good.
So let's talk a little bit about just what AFib is, because it's the weirdest feeling you're going to experience.
Right. Yeah. Yeah, and it's, atrial fibrillation, it's unique because it's sort of perceived very differently by everybody. Some people have no idea they're in it. You can flip into it and have a heart rate of 140, 150 beats a minute, and they have no awareness. So we call that no awareness atrial fibrillation. Other people, the second they flip into it, they feel it, and it can be palpitations, heart racing, shortness of breath, dizzy spells, lightheadedness, fatigue, neck pulsations is one I hear fairly frequently. And really what AFib is, atrial fibrillation, is just where the heart's normal regulated electrical mechanism kind of goes awry. And so the way I like to think of AFib and the way I explain it to people is it's kind of like a short circuit where, normally the heart beats in a very coordinated fashion where the top chambers squeeze and pump blood into the bottom chambers, and then the bottom chambers pump blood out to the body, to the lungs on the right side and to the body on the left. And in AFib, what happens is you just get this sort of electrical storm in the top chambers where the top chambers just start to beat very chaotically. So it's very irregular, very erratic, and whether or not it's perceived kind of depends on the person. The rhythm itself is not particularly dangerous as far as life-threatening. The problem with atrial fibrillation is when the top chambers aren't emptying blood, anytime blood starts to pool and become stagnant, clots can form. And so the concern we have with atrial fibrillation is clot formation and a potential the risk for stroke that is associated with that. So
are there different types of AFib too? I think there's a specific one we're going to talk about, but is there others as well?
We tend to break AFib into valvular and non-valvular.
Okay.
And really specifically what we're talking about there is people who have rheumatic heart disease, rheumatic valve disease, are at particularly high risk of stroke. And so that patient population, we tend to still, in almost every circumstance, recommend blood thinners. The non-valvular atrial fibrillation is basically people that don't, it's every other cause of atrial fibrillation not related to valvular heart disease, and specifically mitral stenosis. So it's kind of a specific valvular disease, what we're talking about there.
And you've said that it is relatively common, isn't it?
Very common.
AFib is pretty common.
Very prevalent. I mean, and it's kind of age related as we get older. Up to a quarter of people over the age of 80, even up to a third, will have episodic atrial fibrillation. And, we kind of break it down into paroxysmal, meaning it comes and goes, persistent, meaning it comes and it can stay for a while, and permanent, meaning it's, you're always in atrial fibrillation.
Right. So there's obviously different treatments that you guys have to take into effect with this. And I know that one of the questions I had when I went through it was, well, what about exercising? And I hear that actually is beneficial.
It is.
In a situation like that.
Right. Exercise is, in fact, beneficial. The things that improve the overall efficiency of the heart and overall heart health certainly are beneficial. It's things like stimulants, alcohol use, sleep apnea is a big trigger. So if you have sleep apnea, that needs to be treated. High blood pressure, diabetes, those are all things that underlying lung disease that can trigger atrial fibrillation. So.
Okay. Is there any connection at all? I don't know why I thought about this right now, but there seems to be some of the doctors we've been talking to about various triggers that happen for various diseases. Did you notice anything in COVID that happened at all with AFib?
Yeah, I mean, there was definitely an uptick in the instance of atrial fibrillation, and whether, there's a lot of uncertainty about causality, and whether it was a direct toxic effect, myocardial or heart toxicity, or whether it was related to the lung toxicity, where you have low oxygen levels or even blood clots to the lung was a pretty common thing with COVID. And that may have been, a trigger for atrial fibrillation. So the AFib, certainly could have been an innocent bystander, so to speak, there. But we did see a number of patients who didn't have low oxygen levels, who didn't have blood clots to the lungs, and the incidence of AFib was certainly higher. So,
wow.
Interesting. Yeah.
Well, one of the you mentioned earlier, or you've been mentioned a couple times now, is the clotting that's a concern with AFib, right? So you've kind of touched on some things like non-valvular AFib or atrial fibrillation we're talking about and how it differs. But and I watched a video on what we're about to talk about today. I have so many more questions, honestly. But there is, specifically with non-valvular AFib, a procedure that's called the Watchman procedure.
Right.
Is this something that's relatively new?
It's been in study. It's been sort of investigated for several years, dating back to 2008, 2009. There was a series of studies called the PROTECT and the PREVAIL trials that started looking at this. And I want to say in the U.S. it was approved in 2017. So it's been around a while.
Okay.
But I mean, relatively new, but in studies for quite a while. And I think the original, what took it so long to get approved was really evolving the device into a safe device.
Right.
So, getting basically the way to think of it is a little plug from the right side, from the vein into the left side of the heart with the heart beating is obviously a bit tricky. And so, the device has evolved to become a very safe procedure. And, but yeah, it's been around for longer than people think, but approved in the U.S., I believe, I want to say in 2017.
Okay, well, let's talk a little bit about this device because, you mentioned all of the trials it has to go through to make sure it's safe and it's become super safe. I think a lot of things people don't think about is, if you have something like this in your chest, what about stuff like, going through airport security? What about MRIs and things? That has to be taken into consideration, right?
Yeah, the metal, it's a nickel titanium alloy, and so it's sort of non-ferromagnetic. It doesn't set off alarms, and just as a precaution, we do give people a card that'll say, I have this device in my heart, and but the metal is not typically magnetic, and so it will not trigger airport security or department store, alarms, which tend to be triggered by magnets.
Like you're stealing something. Explain this device just a little bit. When I was watching the videos on how it worked, it looked like there's, and of course you're going to explain this much better than me, but it looked like there's a section of your heart. Does it only go into that one section?
Yes.
And that's it?
Yep.
When I was watching the video, and this might be the dumbest question you've ever been asked, but the part that device goes into seems like a part of the heart you can shut off. And to me, none of your heart parts seem like they should ever be shut off.
So, it's interesting. It's basically, it's called the left atrial appendage.
Okay.
And the way to think of it is almost like the appendix in the bowel,
Yes.
And so it's probably a remnant of the fetal circulation. and it really does not serve any particular purpose.
That was my question.
But it is the nidus. It's the source of clots in atrial fibrillation in about 92 to 97% of people.
Oh wow!
So, and really, what it is it's just this little again, appendage or appendix that kind of hangs off, and it's very serpiginous. There are little crypts and things in there, which is what really makes it prone to clot formation.
Okay.
And so with the left atrial appendage occlusion device, basically what we do is we go in and we put a plug in. And so that's what the Watchman device is. There's another one on the market called Amulet. And basically what you do is you go in and just seal that appendage off. And what happens is your body will just grow right over the top of the device, and then it excludes that appendage from the circulation. So even if clots form and things like that, they can't get back into the heart and get pumped out to the body. So
where do they come up with the names for these things?
Yeah. They have entire marketing teams that spend all kinds of time.
Oh man, those are both names are fantastic.
They're pretty good.
Honestly.
Yeah, they are. Yeah.
So how does it? I mean, you kind of explained it, but how does it work to prevent those strokes then in AFib patients? Once this plug is there, then what's its function? What's it doing after it's put in there?
Yeah. So again, the vast majority of strokes that occur in AFib come from the appendage, and so if you can completely exclude that from the circulation, those clots and things that form in there cannot get into the heart. They're blocked from getting into the heart, the pumping chambers of the heart. Mm-hmm. And so over time, the body just kind of heals around the device, and it's kind of excluded from all the blood that flows through there. So now, again, nothing's ever 100%. So there are still some circumstances where, for example, if the heart has a massive left atrial, the top chamber is massively enlarged, you can still form clots. Oh. So those people, are a tiny subset that we'd still want to be on blood thinners. But by blocking off that appendage with Watchman or Amulet, after a few weeks, then we can get people off of blood thinners, and that's really the benefit. That's
okay. That was going to be my next question then, because before this was a device that was widely used, it was almost always blood thinners.
Right.
So what makes this device better than blood thinners then? Just the fact that you're off medication at this point?
Yeah, I mean, if you look at the PROTECT studies and the Prevail trials, ASAP is another one. Essentially you have the same stroke reduction. So risk of stroke is very much related to your clinical history. So things like heart failure, previous history of stroke or TIA, diabetes, vascular disease, high blood pressure, age, each one of those it counts against you, and it's additive. So if you add all those together and you have a score of 6 or 7, I mean, your risk of stroke per year is in that 7 to 10% range.
Oh boy, okay.
And so those people, we always recommend the blood thinners. And that's always our first line of therapy, is to put people on the blood thinners, warfarin or Coumadin, apixaban, which is Eliquis, Xarelto, rivaroxaban. So there's a number of them out there. So that's always our first line, and that reduces the risk of stroke to 1% or less. The blood thinners do. But the problem with the blood thinners is the bleeding risk, of course.
Yeah,
so your
exactly.
blood is thin. And so the whole benefit of the Watchman device is to reduce the risk of stroke to 1%. So it's as good as the blood thinners without the bleeding risk.
Oh, excellent.
So it's as effective at preventing stroke, but then you take the bleeding risk out of the equation. So that's
And I suppose any other side effects that people can suffer on blood thinners too.
Right.
Yeah.
Allergic reactions or sure, exactly. That's right.
And I suppose getting off medication at all is just a good thing generally.
Well, and expense, just to throw that out there.
Yep.
Some of the newer blood thinners are very effective, and I use them every day, but they can be expensive depending on what type of insurance coverage you have, and sometimes the newer agents are just unaffordable. Mm-hmm. And so then we're back to the warfarin or Coumadin, which has its own drawbacks, and that it's very erratic, and you have to get your blood checked every few weeks, to follow a certain diet. Mm-hmm. So getting people off the medications does have some merit, no doubt.
Well, explain this procedure then, how it works, doctor. It seems because it's not, you're not cutting into the chest to get this in.
Nope. So the way we do it is we'll do a screening, either a CAT scan of the heart or a transesophageal echo, where you swallow a small probe and look inside the heart and kind of assess the anatomy and make sure people are a candidate for the procedure. And 95 to 97% of people are, based on the anatomy. So we look at the anatomy, and then the procedure itself, the way we do it here is we utilize our anesthesia team. So we bring the patient in, they'll assess the patient, usually put an airway in, so we do deep sedation for this procedure. And then we bring them back to what's called our cath lab, and our imaging doctors will put what's called transesophageal echocardiogram probe. It's just a tiny probe that we put into the esophagus, because the esophagus sits right behind the heart. We get a crystal clear look inside the heart. So that's the majority of what I do, is look at the echo. There's a little bit of x-ray that goes with it. And then my role is I come and put a tiny little tube about half the diameter of a drinking straw into the vein, not the artery, but the vein. We slide a catheter, a long hollow tube, up to the right side of the heart.
In the vein, you're going into the leg, like
in
the
leg,
inside of the thigh.
Right kind of at the crease of the groin is where we go in. We numb that up with a little bit of Novocaine, and then there's a little tiny called a transeptal puncture, where we puncture the membrane that separates the right and the left side of the heart and put our catheter across, and then using the echo, we guide the Watchman device into the appendage and deploy it. And so there's a series of steps where we, get it in position. We can kind of adjust the depth wherever we want it. We deploy the device fully, but it's still connected. And then we have our echo doctor make sure that it's compressed, make sure there's no leak around it. We do what's called a tug test to make sure it's secure. And when it meets what we call our PASS criteria, position, anchor, size, seal, then we let it go. If there are any questions, we can recapture it, redeliver it, take it out, put a bigger one in or a smaller one. So,
wow.
And believe it or not, our average case time is about 26 minutes. So
for the whole procedure, once the procedure starts,
which is amazing. So
it is amazing. And looking at that, the little plug, it just reminded me of a little parachute that opens in there. And like you say, it's like you'd have taken a rubber plug and put it into, a stopper into a pipe.
Yeah,
and
exactly.
It's just pink, and then it sits in there. And the tug test, I love that.
Yeah.
Just a little pull to see.
Yeah.
So, what kind of recovery then happens with this?
So when we're done, I usually put in a little kind of an internalized stitch device, a suture. So we take the tube out that we delivered the device in, cinch down the suture device, and then people will go to the recovery room. And most of the time, our anesthesia team has the patient, the airway, the external airway, the breathing tube out. Patients are awake before they leave the cath lab. They go to our PACU, our post-anesthesia unit, monitor for a couple of hours, and then we watch, the majority of them we watch overnight. Occasionally people go home the same day, but basically bed rest for 4 hours after the procedure, and then they're up and moving around and eating supper, and it's a very, very rapid recovery.
Wow.
Within 4 hours, 95% of people are basically back to normal.
Okay. So you mentioned that 95, 96% of people are eligible for this. What are the ones that aren't? Why?
So one example would be somebody who's got other reasons to be on blood thinners. So blood clots in the legs, or previous blood clot to the lungs. If they've had a series of strokes and despite less invasive or less aggressive medications that continue to have problems, sometimes we leave those people on blood thinners. If they have bad peripheral vascular disease with bypass grafts and we're worried about those clotting off, we would want to leave them on the blood thinner. Okay. So that's a big category. Kind of the valvular atrial fibrillation patients we talked about earlier. People with mitral stenosis, even with even with a blood thinner, I mean, they're at a significant risk for stroke. So we tend to leave them on the blood thinners. And a lot of the reason we don't treat them, or at least it's not on label to treat them, is they're just not studied. They're excluded from all the studies that were done. So maybe down the road we'll get a study that shows it's as beneficial, but as of now, we tend to treat those people with the blood thinners. So.
Okay. So let's say, let's do like a specific criteria or condition for somebody that's a good candidate. Let's say somebody, I'll use me as an example. I had one bout of AFib where I had to go into the emergency room. My heart rate got up to 160 something.
Yeah.
They put me on medication that brought it back down. I was on medication for a few days afterwards just to see what would happen. And then there's been no reoccurring instance of it at all.
Right.
Would I be a candidate for a procedure like this?
Technically, you probably would be a candidate. If you came to me, I would probably say not to.
Right.
You had one isolated episode, and what we do is we try to estimate your risk of stroke. And if your risk of stroke is low, then no, I would not recommend the
that makes
Watchman
sense.
device. I would say, just medical management and follow-up.
Yeah.
It's really the people that have atrial fibrillation, that have an increased risk of stroke, but also have increased risk of bleeding. So that's really the people that we target. So people, a big one is gastrointestinal bleeding, whether due to gastritis or polyps or erosions. That's a very big population for us. So people that have had previous bleeding episodes, or people who are at risk for. So another good example would be somebody with, say, Parkinson's syndrome, who's very unsteady on their feet. They have a tendency to fall down and things like that. Well, you would not want that person to be on a blood thinner. If they fall down and hit their head, that could have, terrible consequences.
So this really ties in very closely to blood thinning medication then.
Yeah, very closely. Yeah. And that's always the big decision is if they're a candidate for blood thinners, they're doing great on blood thinners, they've had no issues, we have a tendency to just leave them alone, leave them on the blood thinner. If they've had issues, though, or, and there's some people who just say, I don't want to take the medicine, I'm scared of the medicine, I live, in the middle of nowhere, and if I have a bleeding episode, I may not make it to a hospital. Those are people that we consider for the Watchman procedure. So,
excellent.
Yeah.
Well, it's a very interesting procedure for sure, and what it ties in with. So start with your family doctor. Obviously, if you have questions about it, or if you find yourself in an ER and maybe something like that happens, should you ask those questions?
Sure. Yeah, and we're happy to sit and talk with anybody. We have at Monument, we have a structural heart clinic, and we're happy to take those referrals and get people in and just go through the pros and cons and who's a candidate and who isn't. We just had our clinic today and saw several Watchman patients, and and some people we decide it's better to just continue medications.
Yeah.
But it's nice to be able to sit down and kind of talk through things with people. And, we have a video where we show them what it looks like and have several devices they can look at. And I always encourage patients, of course, to talk to your primary care team and kind of say, is there any way I can, if they're really worried about the medicine or having issues, to bring that up, and we're happy to take it from there and discuss further. So,
do you ever think that is AFib one of those conditions that you'll always just manage? You'll never completely fix?
That's a great question. And if you had asked me that 15 years ago, I would have said yes.
Right.
But there have been so many advances in the management of AFib, and that is the specific rhythm management. That's, and we've been fortunate enough to have our electrophysiology doctors here, Dr. Barbera, who is here, Dr. Levine, are really just exceptional operators and have advanced the treatment of AFib dramatically. And so there are a number of devices out there now where we can do AFib ablation, where we go in very similar to the way I would put a Watchman in, but what they're doing is mapping in the heart where these rhythms are coming from. So the way to think of it is they're finding where the short circuit's triggered, and they go in and they can use cryo, they can freeze, they can burn, they can do all kinds of things to kind of modify how these impulses are transmitted through the heart. And a lot of times they can create almost a roadblock. So even though the impulses are firing, they don't make it into the heart chamber. So it's a fascinating procedure, and it's evolving very, very rapidly. And in the people that are sort of paroxysmal atrial fibrillation, their left heart chamber is not really enlarged. Our cure rate, basically we cure AFib is in that 75 to 80% range.
Right.
In the right patient, in an expert operator like Dr. Levine and his hands. It's so it's evolved so much. Even in my career, as a fellow, I hated those procedures because you were in there for 4.5, 5, 6 hours trying to burn every little burst of energy. And these days, they can do that in under an hour in some cases. So
that's got to be exciting. 15 more years, where will we be?
Oh yeah, no
that's
kidding.
That's got to be cool. One thing. How do you feel about smartwatches and stuff that can detect that? Are you a fan of stuff like that?
I am. Yeah, I am definitely. I think they've evolved to the point where they're accurate. Number one,
right?
And they have algorithms that they can kind of follow, and I've had a number of patients who have had, notifications or triggers, and they'll call, or they can actually send it to us via PDF file in their chart.
Right.
And it's very helpful, to know when they're going in and out of AFib. It kind of helps us decide, if they've had an ablation, it's been several months or years, and people are going along just fine, and we say, well, maybe we can just stop your blood thinners. It'd be, we don't want them going in and out of AFib, but sometimes a smartwatch can be a really nice mechanism to pick up on that.
Yeah.
And so if it triggers and it's in fact AFib, then it may change whether or not we keep them on medications. And so, yeah, personally, I am a fan of it. I think it gives us ability to monitor people without being intrusive.
Right.
Just wearing their watch.
And just another tool for you guys to use, which is great. Dr. Joseph Tuma, interventional cardiologist at Monument Health. Thanks for coming in again. We've got to do this more, okay?
I agree.
Don't wait another 70 episodes. Come in anytime, all right? I appreciate it.
That sounds great. Thanks for having me.